Hi everyone, welcome back to the second part of the 2017 classification series. In the previous video, we understood one of the most important concepts introduced in this classification, and that is periodontal health. Now in this part, we move into the most important section of the classification, periodontitis. And this is where the 2017 classification becomes truly clinically oriented. Because earlier we mostly focused on naming the disease, but now the focus is on understanding how severe the disease is, or how complex it is, or how fast it is progressing, and what risk it carries for the future. So instead of simply saying this patient has periodontitis, we now describe the disease much more comprehensively. Now, before we begin, there is one major conceptual change you need to understand. In the 1999 classification, periodontitis was divided into chronic periodontitis and aggressive periodontitis. Aggressive periodontitis was considered a separate disease, usually affecting younger individuals with rapid destruction and sometimes minimal deposits. But over time, researchers realized that there was a significant overlap between chronic and aggressive forms, and there was no strong evidence proving that they were biologically different diseases. So, in the 2017 classification, this distinction was removed. And now, all these cases are grouped under a single category, periodontitis. This was one of the biggest conceptual shifts introduced in the new classification. Now, the focus is not what type of periodontitis is this, but rather how severe is it, or how rapidly is it progressing, and how difficult is to treat the patient. Now, according to the new classification, periodontitis is divided into three forms: periodontitis, necrotizing periodontitis, and periodontitis as a manifestation of systemic diseases. Let us understand these clinically. Imagine a patient comes with bleeding on probing, clinical attachment loss, pocket formation, radiographic bone loss, but there is no necrosis and no systemic disease affecting immunity. This is straightforward periodontitis. Now imagine another patient with severe pain, ulcerated gingiva, necrosis of interdental papilla, bleeding, and halitosis. This is not routine periodontitis. This is necrotizing periodontitis, because this condition has a very specific clinical presentation and is usually associated with compromised host response. Now consider another scenario. A young patient presents with severe periodontal destruction along with a known systemic disorder affecting immune function. Here, the periodontal destruction is secondary to the systemic disease. So this is classified as periodontitis as a manifestation of systemic diseases. Now, before we move into staging and grading, there is one very important figure given in the European Federation of Periodontology reports, the diagnostic flowchart. And honestly, if you understand this flowchart properly, the entire diagnosis of periodontitis becomes much easier. So let us go through it step by step. The first question in the flowchart is very simple: is there clinical attachment loss? If there is no attachment loss, we move towards the gingival diseases or periodontal health. But if attachment loss is present, the next step is to determine whether this loss is actually due to periodontitis or due to some other condition. Because attachment loss can also occur due to traumatic recession, cervical caries, third molar associated defects, vertical root fractures, or endodontic lesions. So, if the attachment loss is explained by one of these causes, we do not diagnose periodontitis. But if these causes are excluded and attachment loss is present at two or more non-adjacent teeth, then the patient is diagnosed as periodontitis case. Now, once the diagnosis is confirmed, we move towards staging, grading, and extent or distribution of the disease. So, if you observe carefully, this flow chart is basically converting diagnosis into a sequence of clinical decisions.
Now, let's get back to staging and grading.
So, next we determine how severe the disease is and how complex it is to manage. Now, if you look at this table, periodontitis is divided into 4 stages: stage 1, stage 2, stage 3, and stage 4. And staging is based on two major components: severity of the disease and complexity of the management. Now, first let us understand severity. Severity is assessed using clinical attachment loss, radiographic bone loss, and tooth loss due to periodontitis. As we move from stage 1 to stage 4, there is a progressive increase in destruction. So, in simple terms, stage 1 represents initial disease, stage 2 represents moderate disease, stage 3 represents severe disease, and stage 4 represents advanced disease with loss of function and complex rehabilitation needs. Now, the second component is complexity, and this is what makes the 2017 classification more clinically meaningful. Because treatment difficulty is not determined only by attachment loss, it also depends on the factors such as deep periodontal pockets, vertical bone defects, furcation involvement, tooth mobility, ridge defects, occlusal dysfunction, and bite collapse. So, two patients may show similar bone loss, but their stage may differ depending on how complex the case is to manage. So, always remember this line: staging reflects both the severity of destruction and the complexity of the treatment. Now, one common doubt students have is, how do we calculate the percentage of radiographic bone loss? The concept is actually very simple. We calculate the amount of bone lost relative to the total root length. So first, measure the total root length from CEJ to the root apex. Then measure how much bone support has been lost from CEJ to the current bone level. Now put the calculated bone loss and root length into this formula and you get the percentage bone loss. So if the bone loss is limited to the coronal 1/3 of the root, it corresponds to stage 1 or stage 2 depending on the extent. Whereas bone loss extending to the middle third of the root and beyond indicates stage 3 or stage 4 disease. Clinically, this is usually estimated using intraoral radiographs and by comparing the level of remaining bone relative to the total root length. Now let us apply this clinically. Suppose a patient presents with interdental clinical attachment loss of 1 to 2 mm, radiographic bone loss limited to the coronal third involving less than 15% and probing depth of 4 mm or less, and no tooth loss due to periodontitis. This corresponds to stage 1. Now another patient presents with clinical attachment loss of 3 to 4 mm, radiographic bone loss extending to the coronal third between 15 to 33% and probing depth up to 5 mm with no major complexity factors. This corresponds to stage 2. Now imagine another patient with clinical attachment loss of 5 mm or more, radiographic bone loss extending to the middle third of the root or beyond and probing depths of 6 mm or more, vertical bone defects of 3 mm or more, or furcation involvement and moderate ridge defects. Now the disease is not only severe, it is also complex to manage. So this becomes stage 3. And finally, consider a patient with clinical attachment loss of 5 mm or more, bone loss extending to the middle third of the root and beyond, loss of 5 or more teeth due to periodontitis along with masticatory dysfunction, secondary occlusal trauma, bite collapse, drifting or flaring of the teeth, and less than 20 teeth remaining. This corresponds to stage 4 because now the disease affects overall oral function and requires complex rehabilitation. Now, after staging, the next step is grading. If staging tells us how severe the disease is now, grading tells us how rapidly the disease is progressing and what risk it carries for the future progression. So, now grading is divided into grade A, which is slow progression, grade B, which is moderate progression, and grade C, which is rapid progression. This can be assessed in two ways. First, direct evidence. This includes old radiographs, previous clinical records, or documented attachment loss over time. If these records are not available, which is common in many clinical situations, then we use indirect evidence. And here we evaluate bone loss relative to the age of the patient. So whatever bone loss we calculated in stage, we divided by the age of the patient. Now, another very important concept in grading is risk modifiers. Even if two patients show similar destruction, their grade may differ depending on systemic and environmental risk factors. The two major modifiers included in this classification are smoking and diabetes. For example, consider a patient with moderate bone loss but uncontrolled diabetes. Even though the severity appears moderate, the risk of progression is much higher. So this patient may shift towards grade C. Similarly, heavy smoking can also increase the grade. So always remember, staging describes severity and complexity, while grading describes a rate of progression and risk. Now let us integrate everything together. Earlier, we would simply diagnose this case as chronic generalized periodontitis. But now the diagnosis becomes much more complete. For example, stage 3 grade C generalized periodontitis. In a single diagnosis, you are describing severity, complexity, risk, progression, and extent of the disease. And that is exactly why this classification is much more clinically relevant. It helps in treatment planning, prognosis, communication, and long-term maintenance of the patient. Now, apart from routine periodontitis, the classification also includes two other important forms: necrotizing periodontitis and periodontitis as a manifestation of systemic diseases. And these are clinically very important because the diagnosis here is not based on only attachment loss but also on the overall clinical presentation and systemic background of the patient. Now, first let us understand necrotizing periodontal disease. These conditions have a very characteristic presentation. Typically, the patient presents with pain, bleeding, necrosis or ulceration of the interdental papilla and halitosis. And unlike routine periodontitis, these lesions usually have a sudden onset with rapid tissue destruction. Now, according to the classification, necrotizing periodontal diseases include necrotizing gingivitis, necrotizing periodontitis, and necrotizing stomatitis. If you look at the classification table for necrotizing periodontal diseases, it is actually based on the patient's systemic status and degree of immune compromise. Broadly, these patients are divided into two groups. First, chronically and severely compromised patients, and second, temporarily or moderately compromised patients. Now, in severely compromised patients, the host response is significantly impaired. For example, patients with uncontrolled HIV infection, severe malnutrition, serious systemic disease, or severe infections. In such patients, the necrotizing lesion can progress very aggressively. So clinically, the disease may progress from necrotizing gingivitis to necrotizing periodontitis or to necrotizing stomatitis, and in severe cases, even noma. Now, the second category includes temporarily or moderately compromised patients. These are patients where the host response is affected but not to the same severe extent. Common predisposing factors include stress, smoking, poor nutrition, lack of sleep, poor oral hygiene, and local plaque retentive factors. So, these are the patients we commonly encounter in routine clinical practice. Now, depending on the pre-existing periodontal status, the presentation differs slightly. If the patient previously had gingivitis, the lesion may present as localized or generalized necrotizing gingivitis. and occasionally it may progress to necrotizing periodontitis. But if the patient is already a periodontitis patient, then the lesion usually presents as necrotizing periodontitis. So the important point here is the severity of the immune compromise largely determines the extent of tissue destruction and the potential progression of the disease. And this is why when you diagnose a necrotizing lesion, you should not only treat the periodontal condition, but also evaluate the patient's systemic and nutritional status. Now let us move to the next category. Periodontitis as a manifestation of systemic diseases. Now here, the periodontal destruction occurs as a direct consequence of an underlying systemic disorder. So unlike routine periodontitis, the systemic disease is actually driving the periodontal breakdown. These are usually uncommon conditions, often associated with disorders affecting immune response, genetic function, or host defense mechanisms. Clinically, these patients may present with severe attachment loss, rapid destruction, and a disease severity disproportionate to the local deposits. For example, a young patient with severe periodontal destruction, minimal plaque, and a known neutrophil disorder should raise suspicion of periodontitis as a manifestation of systemic disease. Now, one important thing to understand is in these patients, management is not limited to periodontal therapy alone. The systemic condition also needs to be identified and controlled. And that is exactly why the classification separates this category from the routine periodontitis. So, if we summarize, routine periodontitis is primarily plaque associated with variable progressions and influenced by risk factors. Necrotizing periodontal diseases are acute destructive lesions associated with impaired host response. And periodontitis as a manifestation of systemic diseases occurs secondary to the underlying systemic disorders affecting host defense. So in this part, we moved from simply identifying disease to characterizing periodontitis completely. In the next part, we will focus on other conditions affecting the periodontium, including periodontal abscesses, endoperiodontal lesions, mucogingival defects, and peri-implant diseases and conditions.
Thanks for watching. Follow and subscribe to Gumodont for more simplified periodontics.